Hello, everybody. I'm Peter Hudson. I'm the Director of the Centre for Palliative Care, which is based at St Vincent's and the University of Melbourne in Australia. And first and foremost, I would like to thank the organisers very much for the opportunity to present at this important inaugural International Neuro-Palliative Care Society conference. I'm very privileged to be part of a group that's been working with Benzie in helping establish this society, and I've been privy to a number of significant achievements in seemingly a very short period of time. So big congratulations to the leadership group within the society who are progressing this new collaboration particularly quickly and with a number of good outcomes already, one of which is this inaugural Congress. So thank you again for the organisers for the invitation to be involved. It's an absolute pleasure. So my interest in the area of neuropalliative care began quite a long time ago. My background is in palliative care nursing historically, and so I've been interested in this area for some time. And I've been particularly interested in research related to how we can better support family caregivers within the context of not just neuropalliative care, but palliative care more broadly. I was particularly struck when practicing as a clinician by the fact that some family caregivers who are looking after somebody with advanced disease seem to manage the experience reasonably okay, finding it albeit challenging, but they seem to get it through it, whereas other families seem to fall apart and every day seemed to be overwhelming, and some caregivers were very much stuck in bereavement and somewhat disabled by the experience for a certain period of time. So this led me to a particular interest in this area, and then exploring the research and evidence at the time. There didn't seem to be much that had been undertaken with regard to looking at, how do we systematically assess the needs of family caregivers, and moreover, how do we respond to those needs? So that's led to really 2 decades of work with regard to family caregiver research that I and others have been involved with, not only here in Melbourne, but also across Australia and indeed internationally. So it's, I'm really pleased to be able to shed some insights from my experience of research in this area over that period of time. So before we begin sort of outlining the intent explicitly with regard to the presentation, I think it's useful that we just acknowledge that there are different definitions with regard to what we actually mean by the term family caregiver. So in the context of today's presentation, by and large, when I'm talking about family caregivers, I'm talking about those unpaid or unprofessional people in the community who have somehow been called upon to support a person who's been diagnosed with an advanced disease. And importantly, within this definition of family caregiver, that person doesn't need to be a blood relative, and it could be a family member, friend, significant other. And I would suggest that, when we're thinking about family caregivers, ideally we're coming from the point that we think about at least the bare minimum, the primary or main support person or persons who's involved in caregiving, and that person is identified by the patient or the person who's been diagnosed with advanced disease. And that the role of family caregiver can take on different aspects. It could be physical, it could be social and or emotional, or all 3 of those. So a recognition that a caregiver can be involved in a supportive way, even if they're not involved in direct care. And in an ideal world, hopefully the primary family caregiver or caregivers have been willing to act in that capacity and liaise with the healthcare team to support care planning for the person who's been diagnosed with advanced disease. What I'd like to focus on exclusively today is really answering these two questions. I'll probably spend a little bit more time on the second question, and I do need to forewarn you, there is quite a bit of detail I want to convey, and I'll be showcasing a number of publications, but that's more just to, I suppose, reinforce some of the comments that I'm making and to give you an insight into the breadth of the research in this area. So I won't necessarily be dwelling on some of the publications that come up in the presentation. In fact, I'll move through those probably fairly swiftly, but they'll be there as a point of reference for you if you want to investigate those in more detail in your own time. And probably also too, just to acknowledge that some of those references that I will be providing to support some of the perspectives I put forward are not necessarily exhaustive list or process that was embarked upon to discern or shortlist those. So I'm mindful that there may be other kind of seminal papers that I've missed, but nonetheless, hopefully it gives you a good example of some of the research that's being conducted in this area. So thanks for your understanding about that. That's greatly appreciated. So first of all, with regard to why do we need to improve the wellbeing of family caregivers, I think that this aspect of this presentation, I'm hopeful that I can convince you of this if you weren't already convinced prior to coming to this conference. But I think that I'm optimistic if you're on the fence about this, that hopefully I can get you to be thinking that yes, we do as a field, as an international community, we do need to be thinking about specific ways to improve the well-being of family caregivers of people who have neurodegenerative disorders. So one of the most compelling reasons is that we actually, in the context of palliative care, we have an obligation to try and improve the quality of life of family caregivers, not only during the caregiving period where they're looking after a person with advanced disease, but also during bereavement as well. So this is the WHO definition of palliative care, where this is explicitly outlined. And I know there are different definitions of palliative care used internationally, but by and large, I think this is one of the ones that's most frequently referred to. So we have this responsibility to look after and support the wellbeing of family caregivers. And as a consequence of this definition, which came out some time ago, there's been standards that have been developed in a number of countries which make it also explicit with national standards about assessing the needs of caregivers and responding to those needs as best as possible with the resources we have within the context of palliative care. So what I want to do now is extremely briefly just showcase some examples, as I said before, of some articles that touch on the experience of being a caregiver, the impact of the role, and then the needs of caregivers with regard to family caregiving in the context of advanced disease, but with a specific focus where I can on neuropalliative care. And this helps, I think, demonstrate why we need to improve our support for the wellbeing of family caregivers. So with regard to experience, I'm not going to read out all these titles. I'll just give you a few seconds to read them yourselves. So the experience of burden that many family caregivers are confronted with. the impact on quality of life and the impact of psychological and social aspects for the caregiver as a consequence of their role. Some studies that have looked at the experience and quality of life across several disease cohorts. And also importantly, going back to kind of the remit for palliative care, to focus on the needs, quite a few studies looking at the needs of caregivers within different disease groups as well. Quite a helpful paper from Owen Kim, which looked at the needs from a dyadic perspective. So the needs of, in this context, these were patients with ALS, but also exploring concurrently the needs of their family caregivers, and a recognition that in many circumstances, not all, but the needs of patients and the needs of caregivers are similar in many respects. Quite useful paper, I would have to say, from Bernori and colleagues. Not only have we got a body of work that's recognising the needs of caregivers, but related to that, obviously directly related, what is it that most family caregivers actually want? So I think quite a good paper. The question that came to my mind when taking a look at the literature with regard to the experience, impact, and needs of caregivers was, are the needs similar, or do in fact they vary greatly from disease group to disease group? There's been a little bit of work in this area, but not a great deal. So as a paper I've referred to here. So I do think this is an area that warrants further exploration. And I would argue that in the most part, there are some generic caregiver needs. In other words, there's some needs that seem to be pertinent across caregivers, no matter what the underlying disease is of the person they're looking after. And I'll comment on those in just a minute, but I should also make it clear that that doesn't mean there aren't specific needs and care that needs to be nuanced based on the disease, symptom profile, implications of certain disease, and the trajectory of that disease as it applies to family caregivers. So we all know that the needs of caregivers of somebody with advanced cancer, there may be differences specifically around their needs as compared to somebody with ALS or motor neurone disease. So, for example, the caregiving period for somebody with ALS may be in fact longer for some types of advanced cancer. The change, responding to the changes in cognition, may in fact be a greater burden for caregivers in the context of ALS as compared to cancer. And the tasks of caring may be, not always, more complicated for a caregiver, somebody looking after somebody with ALS who may be on a ventilator, for example, as compared to somebody with cancer who may not need as much intervention. And they're just some examples. But my overarching point here is that I would argue that the most part, the needs are fairly generic. And what the literature seems to tell us is that no matter what disease group, caregivers desire a lot more information and preparation for their role. And I'll talk a bit more about that in detail later on, that caregivers, regardless of the disease group they're supporting, do appreciate more psychological and social support, including during bereavement. And for many family caregivers, they do need assistance with practical advice and skills, particularly if they're involved in some of the instrumental tasks of caregiving. So these needs seem to be generic, and it's important, I think, that we're aware of those. And just to reinforce, I suppose, the impact and needs for caregivers, a couple of quotes that seem quite pertinent, have to me over the years, but it still resonate even now. This is first one from Kelly Stagehar and Betty Davies. This is from quite a while ago now, but I said it's I think it's still pertinent. I'll let you read it. So this is still an issue. I can certainly speak for my experience in Melbourne, Australia. This still happens not uncommonly when a patient's being discharged from hospital, somebody with palliative care needs, and they're kind of advised that don't worry, there's going to be a lot of supports when you get home, when in fact, in some circumstances, there's not much support available, and the caregiver finds themselves quite isolated. And these two quotes. So again, sort of reiterating the importance of preparation and also, I think, preparation for the role and what might lie ahead in the future. But with that second quote, a recognition that for many caregivers, they don't feel worthy of the support of healthcare professionals. So we've got a responsibility to convince them that that's not the case, that as part of the role of palliative care, we are here to support them as well as the person they're looking after as well. So that's quite important for us to be mindful of. So one of the areas I said was around the kind of preparation and information needs. This is a helpful paper from a couple of years ago. And again, these are back to the kind of generic needs around information. So this was a review that looked at caregiver information needs across various disease groups, and a helpful kind of list of common categories of need and some examples that relate to those. And similarly, we could argue that not exclusively, but in the most part, there is a kind of general caregiving trajectory that occurs or stages, and there's two references there, one around stages and one around trajectory points, but a recognition that regardless of the underlying disease that the person the caregiver is looking after, there seems to be some key points or key stages whereby we as healthcare professionals need to be mindful, because they're often key junctions in caregiving where we've got an opportunity to recognise that change and the importance of potentially adding additional support or additional guidance because of that variation to what's occurring in the caregiving role. So in summary, in answering the first of the two questions with regard to this presentation, why do we need to improve the wellbeing of family caregivers? Well, I've argued from the outset we've got an obligation to do so from the WHO definition and the standards of palliative care in many countries, that we've got a lot of evidence based on all that work around the needs of family caregivers that by and large, family caregivers feel unprepared for their role of looking after somebody with advanced disease. And in the most part, from the evidence we have, the care that's being delivered or support that's being provided to family caregivers, one could argue, is suboptimal. Whilst there are some exceptions, and I'm sure there's some very good examples of really good quality support that's being provided. But in the most part, the evidence is suggesting that we really don't have a kind of systematic approach that's applied to assessing and responding to family caregiver needs and enabling them to be more prepared for their role. Similarly, quite a body of evidence showing the psychosocial burden and impact that can occur for many family caregivers. Nonetheless, I think a key message that I'd like to get across as part of this presentation is that the intent here is not to pathologise caregiving as something that's inherently distressful and harmful. That's not the case. Most family caregivers will actually cope with the role reasonably well and will cope with bereavement, again, reasonably well. That's not to say they won't find their role challenging or bereavement challenging, but they will be able to get on with their lives to a certain extent. Whereas, however, there is a proportion, and the studies vary depending on context and so forth, but it seems to be about kind of 30 to 40% of family caregivers who are supporting someone with advanced disease meet the criteria for psychological distress, however one may want to define that. And so there is a proportion of family caregivers that we need to be mindful of who are quite susceptible to negative sequelae as a consequence of their role. So we need to be able to better identify those caregivers and work out what best supports we can action to try and prevent poor psychological and social outcomes. The other reason we need to improve the wellbeing of family caregivers is we know that for most people with advanced disease, they would prefer to be in their home environment, however they describe that. And this shouldn't be the gold standard nonetheless, but for those people with advanced disease, advanced neurological disorders who want to be at home, then for that to occur, 9 times out of 10, there needs to be a well-supported family caregiver for that to be enabled. So again, if we look after family caregiver, we're indirectly looking after the patient or the person with advanced disease. And that's a nice segue to the last reason, which I think is the most compelling in terms of why we need to improve the wellbeing of family caregivers. For many patients or people who have been diagnosed with an advanced disease, if you ask them, what do they want or what's the most important thing for them, there's usually a list of kind of, 5 to 10 items. And one of the items that's there high on the agenda is knowing that the healthcare system is going to be supporting their family caregivers as well. So, by default, by us improving the wellbeing of family caregivers, we're indirectly improving the wellbeing of patients or people who have been diagnosed with advanced disease and having to deal with the implications of end-of-life care potentially. So what I'd like to do now is move on to respond to the second question. So hopefully I've convinced you that we do need, as a community of healthcare professionals and researchers and others, we do need to think about how we can improve the wellbeing of family caregivers. So what I've done is try and structure this part of the presentation across 5 key areas, because my thesis is that if we're serious about this, we can't just take one particular avenue. We need a multi-pronged collaborative approach to improving the wellbeing of family carers. And this kind of multi-pronged approach arose out of some work that I was fortunate to be able to conduct. I was lucky enough to receive a Fulbright scholarship a few years ago, and was based primarily at the Centre of Advanced Palliative Care in New York with Diane Meyer, and was very privileged to work with others in her team and others across the states as well. And then, as part of that work, we developed a strategy or a call to action for improving the wellbeing of family caregivers with serious illness across the US. And these kind of 5 components, we argue in this paper, are what needs to be considered to be able to enact that aim of improving support for family caregivers. So I'm going to move through these fairly quickly, and I'll probably spend a little bit more time on the research component. So with regard to policy and standards, I mentioned before the WHO definition of palliative care, but as many as you will know too, there's been a movement over the last probably 5 to 10 years and advocacy work around making palliative care a human right. And this is a recent paper from JAMA, arguing that the integration of palliative care into all serious illness, so including neurodegenerative disorders, is vital if we're going to live true to that mission of making palliative care a human right. So these types of policy initiatives, I think, can be helpful, but they need to be enacted comprehensively and systematically. Similarly, this is an example of policy or an act. This is in the US from a few years ago, and one that seemed to me to be so simple, and it focuses on, but yet so potentially powerful, with the intent being that for all hospitals, ideally in the US, if someone was being discharged from hospital, there needed to be formally recognised a primary family caregiver, and that caregiver received appropriate information and training, including around medications and so forth, and were aware of the implications of their friend, family member, significant other going home before that person was discharged. Now, I'm not sure how this has played out in terms of whether this has in fact been a game changer or whether or not this has been evaluated, but conceptually and theoretically, this seems to make so much sense to me, and I think something similar should apply elsewhere, internationally. So that's just an example, but I think there could be many others, sort of policy and initiatives that we could develop to improve the wellbeing of family carers. The other is what I've called public engagement. So the notion here is that we can't do this alone. As a healthcare community, if we're serious about improving the wellbeing of family carers, if we just rely on us as healthcare professionals, I don't think we're going to get there, or it's going to take us a lot longer. And if we need to have a groundswell of interest from the lay community, and as you all know, it's for many family caregivers, it's not until, and indeed people living with advanced disease, it's not until they start receiving palliative care they are aware of the benefits that can ensue. And in other areas of healthcare where there has been lobbying from community groups, saying, breast cancer, for example, it can be quite powerful and can be quite influential in terms of funding and resources that go to the sector. And I would argue that in the context of family caregiving, this is where we can potentially do a lot more, and hopefully getting family caregivers on board to advocate for better palliative care and indeed better support for themselves. And I think this is another key area that's probably underexplored seemingly. And we've recently, this is about to be published, in recognition of the seemingly lack of kind of community engagement. So this is within Australia, I might add. We're arguing for a kind of reframing of how we position palliative care, because certainly within Australia, at the moment, by and large, I would argue that it seems to be mostly end-of-life care that we're really providing. And that if we're true to that WHO definition and true to that concept of palliative care from the point of diagnosis of advanced disease right through to bereavement, then we need to be messaging palliative care accordingly, because most people in Australia, and I believe from some literature that I've looked at in some other countries, there's a conception that palliative care is just about end-of-life care. It's only about death and dying. And I know the models and phraseology differs depending on country, and I know the US has got that sort of separation between palliative and hospice care, but it's a bit messy in Australia at the moment. We talk about palliative care, but as I said, mostly I think it's really, in terms of what's being enacted, is end-of-life care. And I know within the UK, there seems to be the terminology of palliative or end-of-life care, so there's a bit of a distinction. So the intent here is, certainly within Australia, the message we're outlining in this article is we've got a confused community who think that palliative care is just about end-of-life care, and that in the most part, dying is dreadful. It's inherently painful, and to be a caregiver in this context is also a terrible experience. I'm generalising, obviously, but we've got some work to do here, and I imagine some other countries about how do we message palliative care. I know that certainly within the US at the Centre for Advanced Palliative Care, there's been some messaging work that's been done there, and I'm sure in other areas of your communities similarly. So I hope so, because I think this is a way forward in terms of that public engagement. There was an editorial, it must be, I think it's 20 years ago now, from the UK, I think in palliative medicine, and it said at the time, there are more than 50 definitions of palliative care. No wonder, that the public are confused, healthcare professionals are confused. And this is still apparent from what I can ascertain, even in the hospital that I'm linked to. We have healthcare professionals that really aren't across, the contemporary definition of palliative care and applying palliative care and the palliative approach from the point of diagnosis of advanced disease, where we know all the evidence is quite clear about, the benefits of providing a palliative approach earlier on in the disease trajectory. So I think enough said, the intent here is we need to engage more favourably with the public. And some examples, so this one from the cancer group in the US about sort of personalising palliative care, so that hopefully people have a more favourable image of it, and not something that is considered lesser care, but quality care, core care, not a kind of a bottom of the ladder type care that's only offered because there's nothing else available, so it's considered less than something else. I think we need to be promoting as this is something that's going to be focus on your quality of life. It's about you. It's about responding to your needs and your family and the family unit. And there's been this, I think for many countries has been involved in the Ice Bucket Challenge around ALS and motor neurone disease and fundraising initiatives, which I think certainly from the experience in Australia have been quite powerful in demystifying certainly what ALS or motor neurone disease is, but also hopefully where possible linking to palliative care as well. So these types of things hopefully can engage the community in thinking about the importance of improving palliative care and wellbeing for family caregivers. I'd like to move on to research now. I'm going to move through this reasonably quickly. So there's been some work done around looking at the priorities for family caregiver research across disease groups. And there's also been some work done looking at reviews of interventions for various groups, including various neuropalliative care disorders. I've just got some examples there. So I'm not going to read out all these titles, they're just there for you to review. And then also some priority setting approaches that are specific to neuropalliative care as well. and other disease groups. So what I want to do with this slide is just give you a summary from my perspective based on those papers I've just highlighted and some other work, to give you my kind of assessment of the lay of the land with regard to family caregiver research in the context of palliative care and where I see the priorities. And as I said, I'm going to go through this fairly quickly, but this slide will be there for a reference point for you for the future. There does still need to be work, despite all the research being conducted, on vulnerable or marginalised groups of caregivers. So there's still many caregivers where we don't know the needs and the impact of their role, and we need to try and identify those groups and conduct research there. Similarly, we need to be doing research around family caregivers in more countries, a lot of research from North America, UK, Europe and Australia, some work in Taiwan, but there are other areas of the globe where we really don't have an understanding of what's happening for family caregivers, for people in palliative care. I would argue that in the most part, however, where we've got a fairly good understanding based on answering that first question right at the outset, why do we need to improve the wellbeing of family carers? I showed you some examples, quite a number of needs, impact, and experience of caregivers. And based on that, I would suggest that where we have that body of work, needs, impact, and experience for a relevant cohort, we need to be moving toward interventions, robust interventions. And I'm a real advocate of that, where pertinent, that we go forward with that. And in particular, it won't be any surprise to you that I'll be arguing that we need to be focusing on preparation, interventions that target the preparation, how to prepare family caregivers for their role, and how to prevent poor psychosocial wellbeing. And related to this, we don't seem to have systematic approaches in place for identifying those family caregivers who are at most risk of poor psychosocial wellbeing, complicated or prolonged grief. So we need to be coming up with studies that focus on those areas. Based on the systematic reviews and meta-analyses that are being conducted, we can't say there's one particular approach that's more beneficial than another. But what seems to be coming across from the literature is that we need to improve our focus. So if we're thinking about designing interventions, we need to be a bit clearer about what the intent is. Is it a supportive intervention? Is it psychoeducational? Is it a counselling intervention? Is it psychotherapeutic? Is it skills focused? Is it behavioural therapy? Or is it a multi-component or single component? So that's where there's been some criticism. I'm not saying that's been the case for all interventions. There's been some really good examples. But as a field, when we're thinking about designing interventions, it's helpful up front if we be a bit clear about that. The big question for us, there's a few questions. What's the most appropriate dose when we're thinking about interventions? I've certainly been involved in one particular randomised controlled trial that our conception was, and this was a home-based visit targeting the primary family caregiver, and we compared an arm, those that got a one-visit intervention versus a two-visit intervention, and we were of the thinking that the two-visit has got to be better because it's double the dose. And what it showed, however, was that the one-off home-based intervention was just as beneficial as the two-visit intervention. So that's an area that we need to think about when we're looking at dose as well. Method of delivery is also an important priority for us as a field with regard to family caregiving, particularly at the moment within a COVID-influenced world. But there is big opportunities with technology and digital health, and some studies suggesting that digital health interventions might be as good as in-person and sometimes better, depending upon the type of intervention and the outcome that we're trying to achieve. So plenty of opportunities there. When we're thinking about moving this field forward to improve the wellbeing of family caregivers, we need to be thinking about, we're talking in designing our interventions, is it better to have a single caregiver or a group of caregivers? So, sometimes we're thinking about, a teaching program for caregivers and a supportive kind of approach, then, a group scenario might be better. But for others, it might be more pertinent for it to be just a single caregiver. And along the same kind of thinking, some consideration being given to, is the intervention best delivered to the caregiver alone or as a dyad? So, there's certainly some good evidence coming out about the benefits of targeting the person with advanced disease and their primary family caregiver together jointly, in recognition that obviously the implications of advanced disease, not just for the person with the illness, but also their family member, and through a joint approach to respond to those demands, there can be benefits. But some other studies showing that for some family caregivers, they actually prefer that time alone to disclose their concerns. So I don't think we can have a sort of one-size approach for all. And as I probably implied earlier on, we need some further research to discern whether or not the benefits of some of these interventions are generalisable across different cohorts or whether they're limited to particular disease groups. The last priority, I would argue, is I think they're all really, really important, but I think this is quite a crucial one. So a number of interventions have been developed, but we're not really clear on whether or not they're implementable. And so by that I mean, are they scalable? Are they feasible? Are they affordable? So I think increasingly, if we're really wanting to get some of these interventions operationalised into practice, we need to be considering these aspects around implementation in order for this to occur, because I think there's been some really good interventions sometimes have been designed and shown to be effective, improving caregiver wellbeing, but the reality is they're never going to get into practice because they're not feasible. And some interesting designs now looking at concurrently looking at effectiveness of intervention and also its implementability. So hybrid type trial designs, which I think are quite helpful for us to consider and certainly might be something worth exploring within the context of family caregiver research. And very briefly, just some resources around research. So often as researchers, we're not sure, which instrument should we use. So this is a group from the US, the Palliative Care Research Group, led by Betty Farrell. This caregiver course, is led by Betty, and they have a repository of family caregiver instruments. So I would encourage you to refer to that. It's a great suite of instruments and measures that you can consider if you're thinking about research in this area. The other resource for you to be aware of is through the European Association of Palliative Care. There is a reference group that's focused exclusively on family caregivers, and it's a free membership, and the intent is to foster evidence-based practice, improving care for family caregivers. So I would encourage you to refer to that if you're interested in finding out more. Importantly, in the context of this Congress, a recognition that research is one of the pillars of our new International Neuropalliative Care Society. So we're hoping that this is an area that you can engage with and learn from, and I would recommend you let others know about this particular domain within the society, as there could be some great learning and collaboration opportunities. So getting towards the end now in terms of the priorities, I've said there's 5 groups. I'm just onto the fourth now. So education and training, and there's two elements to this. So one is around healthcare professionals in a recognition that we need to target systematically ways to ensure there is palliative care content in undergraduate curriculums around palliative care. Certainly within Australia, and what's recognised by this Prague Charter is that internationally it seems to be an issue that we're getting healthcare professionals who are coming out of their undergraduate training who seemingly have no formal educational tuition with regard to palliative care. And if we're thinking about improving the support and wellbeing of family caregivers, well, then we need to have a workforce that has some understanding, core understanding of the fundamentals of palliative care. All healthcare professionals will need to look after a person with advanced disease and therefore support their family. It will be called upon to do that. So it follows, therefore, that there needs to be training cemented in undergraduate curricula to enable that and support that. So we've got an education and training remit alongside the other areas that we need to, it's a multi-pronged approach. But there's also a focus, as I've said, and you won't be surprised by this, in terms of the education and training aspect for family caregivers. So many, and I've outlined this preparation point a couple of times. And it's not just me; there are others that have published around this. Some time ago from the US, and Tang very recently in the Journal of Pain and Symptom Management, looking at the benefits of preparation for caregivers. And so it's not to say that we want to create a perfect scenario and it's kind of a fail or pass situation for caregivers. But many worry about whether they're undertaking the role from a competent perspective and whether or not they're doing the right thing. The last thing I want to do is cause harm to their relative friend or family or significant other. So I think we've got an obligation to field, again, based on the research, so there's solid evidence of the need for this, to move this agenda forward in terms of training and education and preparation for caregivers. So this is just some work that is an example that I and colleagues, again, not just in Melbourne, but nationally and internationally, have been involved with around improving the preparedness for family caregivers and a recognition based on a theoretical framework linked to stress and coping model that came out of the US in the 80s, but still stands firm today, and a lot of others are referring to it as a key way of conceptualising our approaches to supporting family carers. So this is a program that we've embarked upon, and you're welcome to explore that in more detail, but it does focus on improving the wellbeing of carers through preparing them for their role earlier on in the disease trajectory, ideally. And this is just a very recent example. We've been involved in a national initiative, again, around preparing family carers and helping them deal with the implications of the role. As you know, many family caregivers are not necessarily doing this by choice. They've been thrown into this role, usually with minimal preparation, and sometimes don't, in fact, have a great relationship with the person they're caring for. Hence, this notion of loved ones is not always applicable. Sometimes caregivers are referred to as supporting their loved ones, but for many family caregivers, they may not necessarily have a particularly good relationship with the person they're caring for. So this is a national web-based resource that focused on reliable evidence-based information. There's also a great example from the All Ireland Institute of Hospice and Palliative Care in the UK. And I know some examples from Canada with the virtual hospice, and there's, I'm sure there's others that you'll be mindful of. But I think if we can, kind of enact these or enhance these, and it allows family carers to access reliable resources, they're not necessarily need to have somebody in person always to guide them. So the last area around this multi-pronged approach is clinical service delivery. So I've spoken about policy and standards, public engagement, research, education and training, and the last one. And I think that many of you will be familiar with this model, the kind of the triangle of of care, the all, some, few. So what I'm suggesting in this, based again on the research that's been conducted to date, and the policy standards, that for all family carers, and there needs to be a needs assessment, a recognition who's the primary family caregiver or caregivers, a risk assessment, that all carers will need some guidance and preparation for the role. And for some, that might be just a bit of a guidebook or a reference to a resource like I showed you before, the web-based one. Others will need a lot more, depending upon need. And all carers need to have a care plan that's made clear to the multidisciplinary team. So we're not duplicating information requests and duplicating interventions. Some caregivers are going to need more intensive approaches in those areas, and for a few, they're going to need, a lot of extra support, and sometimes that support beyond what we can provide as palliative care experts. We may need to refer on to colleagues for complex management and so forth. So, I would argue from a clinical service delivery model, this is the way perhaps services need to be thinking about how they support family caregivers. So, in conclusion, I've argued that, family caregiver support is core to palliative care, and that in the most part, based on the evidence we have at hand, I would assess it as suboptimal. Having said that, there are pockets of exemplary care, but based on the research we have, it's saying that caregivers have got many unmet needs, and that a significant proportion will suffer from poor psychosocial wellbeing, some of which could be prevented. And that if we are serious about this as an international community of advocates for palliative care, then we need to be taking on a multi-pronged approach, and we need to be influencing others to consider how they may want to work with us to improve the wellbeing of family caregivers. I'm very supportive of this suggestion from Abernathy and colleagues, who recommend that a key measure of quality palliative care should be the wellbeing of family caregivers in the years after relinquishing the role. And I think that, I think we can do this. I think as a community, I feel passionate about what's happening within the International Neuropalliative Care Society. There's just a great sense of action and commitment, and I think that people working in palliative care tend to be very passionate and very driven. And I think we can improve the wellbeing of family caregivers. We've got to, as an obligation, to do this. So let's make it happen. Let's do this. Thank you very much for listening. It's a lot of information I've given you in a relatively short period of time, and I'm sorry for so many references, but hopefully it's given you some justification for some of my thinking in this area, and also importantly, that if you want to explore this area in further detail, you've got some examples of some publications that you can look at in greater detail. Please don't hesitate to contact me. I'm very happy to respond to any queries that you may have, and thank you again for your interest in family caregiving. I wish you well for the rest of the conference, and good luck with your involvement in enhancing neuropalliative care. Thanks again for your time.